engine running.
Absolute genius.
Get this.
Welcome.
This is the show where we bring you
Science.
What that essentially means is
discoveries,
Advances.
Questions. Research.
technology.
Unbelievable.
Without further ado,
This is The Naked Scientists. Hello, welcome to The Naked Scientists podcast, the show that brings you the biggest breakthroughs and talks to the major movers and shakers in the worlds of science, technology and medicine. I'm Chris Smith, and today, depression is going under our microscope, including why this happens, how best to recognise and treat it, and some of the more cutting-edge approaches to reverse out of the rut that some people become cognitively bogged down in. Please note that in this programme we talk about suicidal thoughts and behaviours. Now, what did Abraham Lincoln, Winston Churchill and Virginia Woolf all have in common? Well, aside from being towering figures in their chosen careers, they also battled severe depression. In the past, it used to be called melancholy or black dog, but it's now classified as a serious mental health condition. The symptoms include persistent sadness and low mood and a loss of interest in certain enjoyable activities. It also affects how a person thinks, acts and behaves. While estimates vary, it's widely believed around 180 million people globally experience severe or clinical depression. So we asked Trevor Robbins, who's Professor of Cognitive Neuroscience at the University of Cambridge, to explain what's going on.
Mood does fluctuate a lot, quite transiently within fairly narrow limits for normal people, but depressed people, they really hit the floor and they don't get up from the floor. That's the point. And it gets worse and worse. And so you're in a deep trough that you can't get out of. And that's what leads to, suicidal ideation.
Why does anxiety get mixed up with depression, though? I mean, as in, people present with both. They often say, I'm very anxious, but I'm also very depressed.
I relate it to effects of stress in general. As you know, chronic stress leads to anxiety, and you're trying to do things to cope with it. But if the coping behaviour doesn't work for anxiety, then you've got a problem. Basically, in the brain, probably what happens is that your neurotransmitters, your monoamine systems are very active trying to get you out of this problem, but then they become depleted and it changes your mood dramatically. So this is a really interesting issue, how anxiety can progress to depression and anxious symptoms therefore maintain their place in the spectrum of symptoms shown by depressed people.
So you've said that people end up very down and they just can't get themselves back up again. But in terms of health in general, how does having depression affect a person's life course and their outcomes and their health risks?
Well, for example, all of your goals are going to be frustrated. You're not going to achieve any of them. And that's going to make you very, very unhappy. You feel under attack all the time and critical of your own behaviours. And so it's basically a very negative state. Not only reduce activity, but maybe lead you to impulsive behaviours like suicide.
But why don't we all end up with that? We all have bad days. We all take knocks. We lose people we love. We lose jobs. We lose people. But many of us do bounce back. So why is it that some people are more resilient than others? What gives us that resilience? And why does some people go down and don't get back up?
Well, this is a key question. I think ultimately it depends somewhat on your genetic makeup and your previous experience. Experiencing a bit of stress early on is quite good for you. It toughens you up and recruits those systems which make you bounce back and are resilient to future problems. But there are obviously enormous individual differences, as in all of behaviour, which explain some of this predisposition to depression that some of us will have.
When we then look under the hood, what can we do to actually understand what's changing in the brain of a depressed individual that makes them like that and makes them have a tendency to develop those symptoms?
Well, obviously there are several approaches. One is to actually look at the brain using neuroimaging methods to try and understand, are there, for example, underactive circuits, overactive circuits in those regions of the brain that we know subserve functions of emotion and mood, which are obviously central to depression. And there's a whole lot of research which shows that many of these areas, they're often called the limbic system in the brain, are impaired in depression. They don't function in the same way. some parts of the system are overactive, some are underactive, and so forth. Another approach is a more neurochemical approach, understanding, for example, how neurotransmitters may change in the brain in depression. And there is a common theory, for example, that depression corresponds to a lack of serotonin in the brain, which is a very controversial hypothesis. Serotonin being a very important chemical messenger, which makes some of these limbic regions function properly. And then, of course, that fits in with response to treatments, because many of the treatments we have are drugs which affect these neurochemicals in the brain, like serotonin, also noradrenaline and dopamine, which various studies using positron emission tomography suggest may be altered in people with depression.
Is it that the drugs are targeting those chemicals and changing those chemicals produces the benefit? Or is it that those drugs are doing something that does over time have a mood-altering effect to help a proportion of people? And one side effect is it also pushes up the levels of these neurotransmitters, and they've actually got nothing to do with the underlying mood disorder.
I suppose, the key evidence is if you can demonstrate a deficit in a system, which is then remediated by changing that chemical deficit with the drug. I mean, the chances are then that you have actually done something to overcome a deficiency. But obviously, it's possible that the drug works on another system, which is not absolutely abnormal, but helps to compensate for that apparent deficiency. And to be honest with you, I still don't really think we fully understand this in depression. I think one of the problems in depression is that there's a lot of heterogeneity of symptoms and also probably of brain systems that are involved, both in terms of different areas of the brain and in terms of these chemical imbalances in the brain. So, for example, drugs like the serotonin selective reuptake inhibitors like Prozac, SSRIs, which are commonly used to treat depression, affect serotonin, may be effective in some people, but in many people they're not. And so overall, SSRIs don't get a really brilliant rating in terms of a cure or a treatment for depression, but for some people they seem to work quite well, which suggests that in those people there may be a serotonin problem. And there is a certain amount of evidence that supports that with some experimental studies which transiently deplete serotonin in the brain. It's a dietary manipulation. And those people seem to respond quite well to SSRIs who have depression. So, there's some evidence, therefore, for this kind of heterogeneity. Whereas other groups of depressed patients may require completely different forms of medication or indeed other treatments. For example, cognitive therapy or at the extreme, deep brain stimulation, ECT, electroconvulsive shock therapy. Those are, obviously quite invasive treatments.
You're arguing then that we have this entity we call depression, and it presents a certain way with a certain set of features, but that's like an endpoint. It's an umbrella term for a way that a range of different pathways could lead to. So all roads lead to Rome. Many different neurological impacts could manifest as depression, but they might all be different, and therefore the treatment you need for them may well be different.
Absolutely correct. So, for example, you could have a depressed patient who's suffering from anhedonia, lack of pleasure. That suggests some problem in the reward system. So that they enjoy nice foods, for example, they get pleasure out of that, but they don't get excited about it. But then there might be another depressed patient whose symptoms are very much concerned with guilt and shame and over-responding to negative things in the world.
Trevor Robbins there. The first port of call for someone who feels depressed is usually their family doctor or GP. In fact, most primary care physicians will say that up to a third of the patients that they see some days will present with mental health conditions, depression and anxiety foremost among them. So what are they looking for when a person who might be depressed goes to see them? And what treatment options do they have at their disposal? Munro Stewart is a GP partner in Dundee and he's also a vice president at the Royal College of General Practitioners.
As they walk in the door, there are signs of depression such as moving a bit more slowly, looking down, tone of voice being softer or less eye contact. There are a number of signs as soon as they walk in the door that someone may be suffering from low mood or depression. That is then followed up by open questions from the GP and a good couple of minutes of the patient's perspective and story where you're gathering a huge amount of information.
How do you decide, though, whether this is a blip or whether this is here for the long haul and we need to do something about it?
The criteria for depression would depend on how long they've had these symptoms, as well as the severity and how much of the day they are suffering from them. So I might ask a question like, how long has this been going on? And then if they tell me it's been a few months, I'd say, is it most of the day? Is it most of the week? Is your mood very up and down? Is it up and down but mostly low, or is it just mostly low? And then you can get a real idea of if this is something that has been going on for a long time or if it's a very short time, and that is a key part of the diagnosis.
And what about threats to a person's own self-harm and so on? Do you try and explore that fairly much up front to reassure yourself or otherwise where that situation is leading?
GPs will do a risk assessment with every patient. They have a lot of information on the risk from parts of the story, about how they talk about their family, about making plans for the future. But patients are comfortable, in my experience, being asked, have you had any unpleasant thoughts of self-harm or suicide? And usually you get an honest answer, or you'll get some cues or hesitation that encourage you to probe a bit more.
Do many people who are depressed actually seriously contemplate suicide? Or is it that actually that's quite a rare thing and most people just say, look, I just want to feel better?
Most people that we see in general practice would just want to feel better, but it would be a significant number that have serious suicidal thoughts. We do see that most weeks, so it is a big number, that people that do have suicidal thoughts that are coming along with intent and sometimes planning.
And I suppose people who are really serious about it might not actually come to you in the first place, so what you're seeing might be a bit of a clinical iceberg.
Yes, that's right. If someone has very high levels of intent, then they possibly wouldn't come at all, or they might have been brought by a family member. But yes, often with men, I'll say to them early on, you'll do well because you've come to see me. It's the ones that don't come that we worry about, that are hard to reach.
What do you then do? How do you then start to manage that situation? So you've reassured yourself that this person isn't at imminent risk of doing something to harm themselves, but they do want to feel better and they're clearly unwell. Their life is suffering and their quality of life is suffering. Where do you go next?
Take a steer from the patient as to where they want to go. So I'll maybe ask them something like, before I give you suggestions on how we can make progress, had you had ideas as to what would be useful for you? Do you know what you need to get back to your usual self, get back to where you want to be? And most times get a bit of a guide from the patient as to where they are with different treatment options. They might say straight away, I definitely don't want medication, or they might say, I've tried everything and I really want to try medication. So usually you'll get a guide from the patient, and that's what we're trying to do, is work with the patient and have an individualized, patient-centered approach.
And what sorts of medicines do you have in your medicine chest that you can begin to throw at the problem?
We have SSRIs, selective serotonin reuptake inhibitors, usually first line. We have SNRIs, serotonin and norepinephrine reuptake inhibitors, often second or third line. We have medicines like mirtazapine, which are often first or second line, and then rarer antidepressants like tricyclics and monoamine oxidase inhibitors.
People often say, I don't want to try these things, or that they're dissuaded away from them because they're concerned about long-term dependency or side effects or both. So take us through that. What's the risk of, once you start down this pathway, you're going down a one-way street?
If they do have the indication for it and we can manage it without medication, we'll look to do that first. But yes, sometimes medication is indicated, the patient does want it, and we do see benefits a lot of the time. I wouldn't say that these medications are addictive, but we do have to be clear that if you take them for any length of time and you stop them suddenly, you can get withdrawal symptoms. And that we need to be clear with patients is being careful not to stop them suddenly, and not thinking that you're addicted when you have side effects from stopping it or withdrawal effects from stopping it. It's just that we need to do it gradually.
And those withdrawal effects, is that basically the mirror image of how you feel when you are taking them? So if you feel more centred, if you feel a bit like you're on an even keel and you suddenly stop, there's a risk it'll upset the apple cart and you feel all wobbly again.
Yes, you can do. People will talk about feeling a bit shaky. They might have a recurrence of their symptoms. Some people talk about funny electric shock type feelings in their head. Stomach upset would be another common one. And it can be very unpleasant to have withdrawal symptoms, which people can then fear means that they're stuck on medications, but it doesn't.
What about the downside in terms of just physically taking that pill? What side effects does it have?
We'll always mention the side effects. Common ones that I would mention: the delayed onset. It might take 4 to 6 weeks to have full effect of the medication. We would mention that it can sometimes, instead of giving you the normal highs and lows of being reactive to your day, it can leave you a bit unreactive, a bit flat in the middle with your mood, which can be strangely unpleasant, actually. We see anorgasmia quite commonly, so a lack of ability to have an orgasm. Stomach upset often settles down within the first few days. And I do mention that if you take these very long term, there is some evidence that it can impair your brain function. The biggest risk is in young people of having more suicidal thoughts. In fact, it's not just young people, but it's more commonly seen in young people that you'll have more suicidal thoughts. So there is, oddly, a slightly higher risk of suicide at times when starting antidepressants.
Munro Stewart at the Royal College of General Practitioners. And trials show that about half of the people who try antidepressant medication will report that they feel better subsequently, although it can take significant amounts of time.
The Naked Scientists podcast is produced in association with Spitfire, cost-effective voice, internet and IP engineering services for UK businesses. Find out how Spitfire can empower your company at spitfire.co.uk.
Music in the programme is sponsored by Epidemic Sound, perfect music for audio and video productions.
This is the Naked Scientist podcast with me, Chris Smith, and today we're examining why it's hard to treat depression and how some new innovations offer some fresh hope. Now, diagnosis and medicine are usually only part of the treatment for someone who's diagnosed with depression, with people usually also being offered therapy. The concept of healing through words dates back, in fact, thousands of years, but it wasn't until the 19th century that we shifted towards diagnosing and treating mental health conditions through actually talking. It was this development that helped to establish the foundation for modern psychology. Jackie Rogers is an accredited psychotherapist at the British Association for Counselling and Psychotherapy, and I began by asking her who might come to see her and what that involves.
Person have referred themselves because they want to go privately, or sometimes an employment assisted program that they've contacted me and they want to work with their depression. So the tools I would have would be counselling skills. I can use counselling, so allowing somebody to talk, exploring their feelings, and then I also can do a bit of interpersonal therapy. So that would be looking at who have they got around them that can support them.
Do you actually find yourself also seeking to try and validate the self-diagnosis that someone may have made? Because someone might come to you and say, well, I'm depressed. Do you question that and make sure that they really are, or whether there might be something else going on?
Yes and no. So I would acknowledge what they're saying. When people say I'm depressed, it's a word that's used quite a lot. It may be just low mood. So I'd explore, what does depression look like to you? Get them to tell me about their depression.
And that enables you to then validate that's definitely what's going on here. Therefore, the right way to perhaps attack this would be X, Y, and Z.
It's through exploring their feelings and stuff like that. So it may be a session or a couple of sessions. So sometimes I've got a measure called a PHQ-9. That is a depression score. And I'll ask the client if they want to go through that and measure that. But I treat the client rather than the depression. Does that make sense? Because a depression could be a label. So I look at the person rather than the depression.
And what does success look like to you? What are you trying to achieve for that person?
The first session would be asking them what their best hopes for therapy would be and how do you know when you get there. So they'd say something like, I want to be happy. How do you know what happiness looks like? When I look at success as such, when somebody's depressed, they'll have no motivation. So by the end of therapy or near the end of treatment, they're going to have some sort of spark in them. They're going to be doing more. So that would be my goal, or a marker that they've recovered or recovering from depression.
Has anyone asked, or presumably they have, how it compares when you do the sorts of interventions that you offer compared with the sorts of benefits people might or might not get from a packet of pills? What's the comparison?
Well, there's no side effects from therapy for a start. I'm not against medication, but medication can obviously give side effects. But also the serotonin that you get in some antidepressants, you can create your own serotonin by doing things that you enjoy doing, like getting outside or doing some sport or some movement, some exercise, or mixing with other people. You can create those chemicals yourself. But again, I am not dissing any medication because it has its place, certainly.
When you take people through the various manoeuvres that you as a psychotherapist have to try to bolster people's mood, make them more resilient, reduce their anxieties, and get them feeling more positive, how do you think that's actually working? Or what are you helping to achieve in their mind and in their brain that they are not able to do themselves?
I think when you're depressed, you've got a very negative internal dialogue. And I think that our loved ones will be saying, we'll be telling them that, you can make it, you're fine, but they won't believe them. So I think as a stranger, which I will be as a therapist, I'm hopefully reinforcing a more compassionate rather than a critical voice. Depression's very critical, whereas compassion, so I'll be validating what they're feeling, but also that depression's an illness and they will get better. And they're not the only ones that are depressed. It is recoverable from, so it's more, I'll be encouraging compassion.
How do you actually measure success then? Because one of the things that must be difficult is if you're just asking a person subjectively, how do you feel? Everyone feels different day to day. So how do you gauge that people are moving in the right direction in general?
Their body is lighter, it's less tense, the muscles aren't so tense and they feel lighter and they can see more of a solution.
Because psychiatrists, the first thing they write down in the history when they see someone is appearance and behaviour, isn't it? So I suppose you're doing exactly the same thing. You're saying, how does this person look when they walk in the door? Absolutely.
Are they looking dishevelled? Got no respect in your appearance in a way, but when you're feeling better, they're standing up straighter. There's a difference about the way they're presenting. Their voice will be more clearer. They won't be talking to the feet, they're possibly making more eye contact and they're becoming with a sort of like spring in the step, completely different.
And indeed, about half of people with depression who talk to someone like Jackie Rogers will see improvements in their symptoms and their quality of life by the end of the treatment. Nevertheless, that does mean that some people, and it can be as many as 30%, just don't get better with any of these sorts of interventions, both first-line medications and also talking therapies. They have what's been broadly dubbed treatment-resistant depression. And neuroscientists think that at a basic level, this might be because in some people, the brain learns to be depressed and it becomes very good at it, optimising certain pathways that lead to relentless, intrusive negative thoughts that end up drowning out the positives in life. And it's in this context where more invasive and dramatic interventions like ECT, electroconvulsive therapy, and even psychosurgery, cutting nerve pathways in the brain, have emerged. More recently, electrical brain implants, as well as drugs like ketamine and hallucinogenic agents, have begun to be explored with, thankfully, encouraging results. I asked David Nutt, who's Professor of Neuropsychopharmacology at Imperial College London, to take us through some of these treatments, both past and present, and how they're thought to give relief.
Well, the first real innovation in treatment-resistant depression was the development of ECT, electroconvulsive therapy, which actually was invented to treat schizophrenia, where it has marginal effects. But it was discovered that it definitely lifted depression in people who had chronic illness. And it was a revolution at the time, because before then, there weren't therapies for treatment-resistant depression. ECT involves essentially giving someone a seizure. So you put electrodes either side of their head, you pass a current through, and they have a fit. The fit itself lasts about 30 seconds or more to have a therapeutic benefit. The problem with ECT, of course, is that after the fit, it takes a while to come round. And also, fit can incur muscle spasms, and also if you get a lot of them, you can have fractures of the bones, etc. So ECT was quite rapidly modified so that people didn't have muscle spasm. They put muscle relaxants in so that it was much more tolerable. And then it became the mainstay of treatment-resistant depression therapy, and still is. In the UK, for instance,
Is it not dangerous, though, making people have a seizure, uncontrolled neurological activity for a reasonable period of time? Is that not bad for your brain?
Well, it definitely heals depression. It's not particularly good for memory, and that's one of the downsides of ECT, which is that they lose bits of long-term memory. It improves short-term memory, which is badly affected in depression. But yes, it's not an ideal treatment for those reasons. But it is safe because it's done in a hospital with an anaesthetist, so it's not an uncontrolled seizure, and the seizures rarely last more than a minute.
So when you're making someone have a seizure, why does that lift depression, do we think?
Well, that was obviously a topic of enormous research interest, including some of my very earliest work. And it turns out that ECT turns on, in a progressive way, different neurotransmitters. The first thing ECT does is turn on the dopamine system. And then after a few more seizures, it turns on the noradrenaline system. And in the end, it turns on the serotonin system. So three of the main monoamine neurotransmitters, which are necessary for appropriate levels of mood and different aspects of mental functioning, are enhanced by ECT.
Is that effect indefinite, or do you have to keep doing this to get the relief?
You can see an immediate effect for a few hours after the first seizure. People are eating and drinking. But to get what you might call a full antidepressant effect normally takes between about 6 and 12 seizures, and they're normally given twice a week. And then the effect can be very enduring. The effect can last for months or years, but often depression does come back. And then people are given a choice, either having some more ECT. Very often we put people on a mood stabilizer to try to keep their mood improved after ECT.
We also hear people talking about the question of brain stimulation, putting electrodes into the brain chronically and delivering impulses, which also has a mood lifting effect. Is that a sort of modern counterpart or a safer alternative to ECT? Does it work the same way but is basically a bit kinder?
Yes, it does. And in fact, the idea of deep brain stimulation came in part from the work on ECT, showing that ECT enhanced dopamine function in the brain. And most of the experimental work on deep brain stimulation happened in Parkinson's disease, which of course is a disorder of dopamine function, with dopamine levels falling. So the technology of deep brain stimulation was developed, and about 120,000 people in the world now have electrodes in their brain to help them overcome the symptoms of Parkinson's disease. That technology was then developed for depression by a lady called Helen Mayberg, who realized that in depressed people, there was overactivity in a certain part of the brain, in the prefrontal cortex. And that was a very important paradoxical finding, because until she discovered that, which she did using brain imaging, we had assumed that depression was a loss of the ability to feel pleasure.
Where does that part of the prefrontal cortex project to? So when it's becoming too active, what is it doing to downstream brain areas, and which downstream brain areas, and why does that translate into this profound dark mood that when you turn that single cluster of nerve cells off, immediately lifts the depression?
That's a question that we're all still trying to resolve. In part, it seems to project down and suppress the serotonin system, but in part it also seems to lock higher cortical regions, the cortical regions in which we do our sort of thinking about ourselves, when we reflect on our capacities and our competencies and we challenge our decisions. It seems to change the tone of those and put people into a negative mood state. And it seems to lock people into that state of what we call rumination, where they cannot stop thinking about mistakes they've made. They cannot stop having beliefs of guilt or incompetence, etc.
Is it that is what lies upstream of the depression, because they ruminate on the bad stuff? And if I spent all day thinking about bad things and things I thought I'd done wrong or not done as well as I could, I think I would end up with a low mood. So is it because it relieves people of those intrusive thoughts that it breaks that cycle?
That is exactly right. Absolutely. But the thing with the deep brain stimulation is you've got to keep doing it. It's a sort of tonic shift in belief about oneself. What we would like, and where modern research is going, is to try to avoid having to continually stimulate a system, but to rectify those abnormal thought processes. And that's where the modern treatments of depression, such as ketamine and psychedelics, come in, because they can profoundly disrupt networks of negative thinking after maybe one or just a few doses.
Is the effect persistent? Because obviously those things do have significant side effects. Patients who have been in trials have had some quite negative experiences doing it, not least because one of them, ketamine, is quite sedating. Psychedelics can give people unpleasant experiences as well as hopefully relieving their depression. So is this again like ECT? You do it a bit and then you get some long-term relief, or do you have to keep doing it?
I'll start with the easy answer. Psychedelics like psilocybin, where there have now been over 10 RCTs of psilocybin in depression, largely treatment-resistant depression, a single dose of psilocybin, a single trip, can produce enduring benefits, which in the latest German study, which is not yet published, persist up to 1 year. So you can, in a sense, in some cases, reset those abnormal thinking processes. Ketamine is more complicated because ketamine initially developed as a way of lifting mood. The effects of ketamine last for 2 or 3 days and then are repeated. So current ketamine therapy relies on giving it twice a week or 3 times a week for a period of weeks or months until eventually the depression lifts or it doesn't. However, what we and others are doing is saying, well, ketamine has brain effects which are rather similar to those of psychedelics. And maybe if we use ketamine like a psychedelic, give a bigger dose and have therapy around the trip, we might get better outcomes. And so the current debate is between whether you use ketamine as a sort of prophylactic over weeks and months, or whether you use it 3 or 4 or 5 times over, say, a month and try to get a bigger benefit, which then is enduring.
Thought-provoking stuff. Thanks very much to David Nutt at Imperial College London. Well, it's nice, of course, to end on a positive note, but the reality is that more people than ever are ending up with mental illness. Rates are up nearly 50% in the last 30 years, and government figures say that 1 person in 6 in the UK is now using antidepressants. So although we've looked at how to manage this problem this week, as ever, prevention is always better than cure. So we must keep asking what lies beneath this dramatic increase in mental ill health and what we need to do to stop it. We're back on Friday with the latest in science news, including how new mRNA vaccines might help to break the back of the Ebola outbreak, which is kicking off in the Democratic Republic of the Congo. We'll also have our usual updates on LinkedIn, on X and on Instagram. And if you would like to support our work, please do head over to nakedscientist.com/donate. We are really grateful. I'm Chris Smith. Thank you for listening. And until next time, from all of us here at The Naked Scientists, goodbye.